Welcome. We are so excited about your interest in the Wiley Protocol. We have 3 sections for you today. The first one is the theory of rhythmic dosing in the Wiley Protocol. The Wiley Protocol is a new paradigm, and we're calling it BBHRT, or biomimetic bioidentical HRT. I'm sure you've heard of hormone replacement therapy, which refers to big pharma. It refers to static dosing. It refers to synthetic hormone-like drugs. And you've heard of bioidentical, which are plant-derived. They are estradiol, progesterone, testosterone, and even some cortisols. However, biomimetic is a brand new idea. To mimic biology with the dosing schedule of bioidentical hormones is something that has never been tried before. So the Wiley Protocol, as a new paradigm, is real hormones, only plant-derived, real restoration with the rhythm, not just replacement. It's multiphasic cyclic dosing, and of course a menstrual period on day 28, unless your patient has no uterus. Real solutions. The majority of menopausal symptoms seem to have been eradicated, and there's a vast improvement in sleep and libido in the patients on rhythmic dosing over the last 10 years. The life expectancy in the age of menopause has not changed. We're looking at 1850 to 2000, virtually 150 years. While life expectancy increases, people used to die at 60, 65 now. I think for a woman, the life expectancy is something like 82. The age of menopause has never changed. And we are talking about going through the Industrial Revolution, the advent of electricity and lights, changes in food supply, trauma, World War I, World War II, women went to work for the first time. Nothing has changed the age of menopause. So, as a clinician, as a physician, why would you treat this natural state that seems to never change? The problem is BBHRT, biomimetic bioidentical hormone replacement therapy, not only relieves symptoms, but unlike its counterparts with static dosing, both synthetic and alternative, it preserves health and it protects women. The menopausal symptoms women face from sometimes their late 30s on, acne, Alzheimer's, bone loss, decreased libido, depression, heart disease, cosmetic things like facial hair, quality of life things, urinary tract infections, tinnitus, vaginal dryness, migraines. There's certainly immune dysregulation, hot flashes, flushes, and heart palpitations are all very scary and destroy, again, a woman's quality of life. Now, then there was the Women's Health Initiative. So our question here is, why would you try any kind of HRT at all after the WHI, which told you that the least hormone for the least amount of time was the way to go? Well, I think you would treat it because the outcomes of menopause, increased insulin resistance, weight gain, higher cholesterol, massive inflammation, can lead to heart disease, diabetes, cancers, loss of sleep, loss of well-being, and loss of love, or at least a love life. Remember, the Women's Health Initiative did not exactly examine actual hormone replacement. Prempro, which they looked at for over 18 years, is a drug with very low dose hormone-like effects. It was dosed like Prozac or any antibiotic. Real hormones, real hormone molecules, do not exist in any static way in the body. So the WHI didn't tell us anything except that giving hormone-like drugs in low doses to women over 65 gave them heart attacks and blood clots. We know that. And we know that the women on Premarin alone actually showed benefit for breast cancer. So the WHI was confusing and almost useless in terms of your clinical practice. No, don't give people synthetic drugs. That would be what you'd come away with. Not, don't give women hormones. Bioidentical compounded hormones don't display the same side effects profile as synthetic drugs. And FDA-approved pharmaceutical Prometrium, which is bioidentical and oral, and the Vivel patch, which is bioidentical and transdermal, are both, bioidentical formulations, but even though they're not synthetic, they don't do the job because they're statically dosed. But they're currently considered the standard of care alternatives to old school Prem-Pro for doctors who were paying attention to the WHI, and they're looking for estrogen progesterone replacement for their patients. I'll tell you, it's not enough. Oral P4 and transdermal bioidentical side effects. Anything oral, and we tell women don't swallow a hormone. Oral micronized bioidentical P4, which is Prometrium, creates sleepiness. There's a soporific effect, like first trimester pregnancy, because of the metabolites out of the liver. Oral bioidentical E2 will produce changes in C-reactive protein from the first pass on the liver, which puts a woman in line for blood clotting. And all those clotting factors in the liver are very touchy. So you don't want to swallow hormones, any kind, bioidentical or synthetic. This new idea I'm offering with the Wiley protocol, cycling transdermal bioidentical estrogen and progesterone to bring on a period or mimic menstruation, is not that new. Cycling to protect the endometrium from hyperplasia is a very old idea in synthetics. Before Prem-Pro, there was Premarin and Provera. And now many prescribers of bioidenticals use Prometrium and Vivel patches to recreate an estrogen cycle, as you can see at the bottom, and adding in a progestin or progesterone for 10 days at the end, which is illogical. Any kind of progesterone cycle is always 14 days. However, cycling into any kind of 28-day estrogen regimen, as long as it's static, will not achieve the potential of real biomimetic restoration. The biological events of a normal reproductive menstrual cycle in a healthy young woman look like the chart below. Estrogen is low for 5 days while it pushes the endometrium off at the stem cell level. FSH is pouring, ripening new eggs, and also helping to push off the endometrium day 1 to 5. As it rises, the estrogen, we see receptor responses change every 3 days. And at the peak on day 12, we have absolute critical state where genes are turned on and off and endocrine systems in feedback loops continue. So on day 12, estrogen hits the brain. Now those eggs have ripened and put estrogen through the bloodstream. And on day 12, the estrogen hits the brain and LH is spiked. That LH in a normal young woman causes the ripened egg to pop. The corpus luteum, which is the broken egg sac, produces progesterone for the next 14 days while estrogen continues to dribble. So we see day 14 event of LH. We see day 12 event, which is the feedback loop to the brain, G1 arrest and the provocation of progesterone receptors. for day 21. On day 21, progesterone in its own receptor creates apoptosis, osteoblastic activity, and remyelination. And then day 28, as we say, the fat lady sings and the progesterone drops off and we would have a period again. So this cycle goes on and on exactly like this, with slight seasonal changes in receptor response thanks to thyroid changes and cortisol. And unless the woman becomes pregnant or is breastfeeding, this is the state we live in from adrenarche through puberty to menopause. Very long time of dancing with the moon, light cycles, and the earth. Now, this is nothing like life and health in the human woman. These are hormone levels taken from using a combination pill, and a combination pill is no different than continuous combined hormone replacement with Prempro or with Prometrium and a Vivel patch or estrogen cream. You can see it looks like a bad TV screen. It is nothing like human nature. You're hearing me in a sound wave and you're seeing my slides in a light wave. Everything in nature, every cue, whether it's light, sound, food, radiation, all come to you in waves. The difference in the waves are the wavelength, how close are the peaks, or the amplitude, how high do the peaks go. You can see the dotted line in the middle. If you dose someone along the dotted line in the middle, you never get amplitude. You never get wavelength. You never communicate the environment down to the nucleus of the cell through the hormones, because the light hits my skin and a cascade of events, biophysical events are set off that go all the way to the nucleus in the cell and provoke a new hormone receptor for the next part. And when you dose some woman with the dotted line, it's like she's dead. She's not receiving the environment. She's not responding to physical cues that keep us spinning with the planet, that keep us in day-night cycles, that keep us in love, actually. What's really biological, the pulsatility and amplitude are just like beat and pitch in a song. In the slide, or in this chart below, we are looking at estrogen over the course of a woman's lifetime, 0 to 60 years old at the bottom. Now we see at puberty, the pulsatility and amplitude wavers, and the wave space is very far apart, and the amplitude's building steam. But by the time she's 13 years old, things are getting tight, even, and normal. That continues, that amplitude, in that tight formation until she's about 28, 29 years old. Then it starts, well, really, I'm sorry, about 20. At 29, it starts to fall off. And as it falls off, we see disability. Pregnancy past 28 is called geriatric. We see growth hormone fall off at the receptor level. And by 40, we see the woman in a very low state. And by 45, we're starting to unravel that nice, tight rhythm. If you want something more relatable, we all get in the car at 13 and turn up the music because we can hear the waves. We all get in the car at 45 and say, could you turn that down, if we're lucky enough to have children. So being young is a particular state that is identifiable at the endocrine level, at the genetic level, and on the social level in real life. Biological events of a normal reproductive cycle in a young, healthy woman, again, look just like this. Estrogen's growing things, progesterone takes them away. Proliferation only happens day 1 to 5 at very low levels. So giving a woman very low levels of estrogen causes massive proliferation in breast and in anywhere cancer is about to happen, because there's no way to hit G1 arrest if there's no day 12. Day 12 stops cells from growing and provokes a progesterone receptor for day 21. Day 21 takes the debris away. It's called apoptosis. It means falling away from life. It's very important that those two peaks exist exactly like that. The endocrine feedback loops, the reset buttons and thresholds for genomic action, look like this. We are seeing luteal secretion. Production of LH and FSH decreases because the feedback from the ripening eggs, estrogen, turns off FSH. That's how you know when a woman comes in and her FSH is beyond 5, above 5, in blood work she's probably in menopause because she has no estrogen feedback loop. The LH is spiked by that peak of estrogen, and then we get the corpus luteum to release an egg that has been ripening, creating estrogen. That corpus luteum produces the progesterone. So in this picture, estrogen's building the epithelial cells, the endometrium, and progesterone's going to come in and clean up the system so we can start over again, should no pregnancy occur. Real replacement must provide a bleed every 28 days, assuming the woman has a uterus. You can see in these graphs how the development goes. LH starts the eggs ripening. We get a peak of FSH and then LH. And then in the second row, we see that estrogen has risen and we've got progesterone coming in. In the very bottom, we can see what's happening in the tissue itself. Day 1 to 5, we're pushing off the old lining. But as progesterone happens, it's controlling something called vascular endothelial growth factor. Progesterone in its own receptor vascularizes the endometrium adequately, not only so it could nourish an implanting egg, but so the lining on day 28 will fall out with no clots and no cramps. Now, it bears mentioning that progesterone's control of VEGF, vascular endothelial growth factor, is also apparent all over the body. And particularly in the cardiovascular arena, we saw that progestins, not progesterone, in the Women's Health Initiative fit in those receptors, gave a very different message, and caused blood clots, strokes, and heart attacks. So it must be real progesterone. It must be in a real progesterone receptor. And it must have the timing to get that receptor from the peak of estrogen before it. Real replacement that provides a real bleed, as I have said, if you look at the words above the chart, the peak of estrogen provides G1 arrest, a progesterone receptor, and spikes LH for women who still have ovaries. They can make their own testosterone. If they've had a hysterectomy, or if their adrenals, which help with that progesterone and LH effect, are shot, if their adrenals are over 65, you may want to give them testosterone. But we see here LH should spike their own. Once we have that progesterone receptor from day 12, we will put the progesterone in and get apoptosis, which controls P53, P21, and vascular endothelial growth factor. All of those things very necessary to heart health, the stopping of cancer, and it even affects IRS1, which manages your blood sugar. So just have a look at that picture for a minute. And remember, genomic thresholds of action can never be tripped by flat lines, same dose every day, static hormone treatments, even if it's real hormones. It's the rhythm that matters. What about breast cancer? The 800-pound gorilla in the room. If high estrogen causes cancer, why does cancer happen as your estrogen falls? In the first graph, you'll see cancer starts to rise at age 29. Age 29, as I said, 28 is a geriatric pregnancy, 29 is the fall off of growth hormone, and we see a steady increase until death. If you look at the slide we've seen on the right, you'll see that estrogen rhythm protects women all the way to 60. Now, can you start a woman on hormones at 60 and get a response? Absolutely. But can you start a woman on hormones at 29 if she's done having children, of course? At 29 and get a better response? I would tell you the sooner you replace and restore normal rhythms, the better health and longevity you're going to see. Actually, the statistics tell the story. The ABCs of breast cancer, epidemiology, risk factors, and genetics. This is from the British Medical Journal in 2000. This is old. Age is a factor, relative risk, but you can see the high-risk group is the elderly, and the elderly have no hormones. Geographical location, developed countries. That's in another book I wrote, The More Light and Food you are exposed to and the less sleep, the faster you age. Those are the hallmarks of a developed country. You snooze, you lose, you work 24 hours a day. You can have any food you want. That's the hallmarks of developed civilization, the diseases of civilization, cancer being one of them. All that's in a book I wrote called Lights Out. Age at menarche, we're getting a 3. Age at menopause, we're getting a 2. Age at first full pregnancy, we're getting a 3. Now that insinuates the high-risk group is a child in their early 40s. So the question for you, doctor, is having a child better for a woman in her early 40s than having none ever? Statistically, no, it's not better. However, we have a group of women who looked up and forgot to have a baby and would like to experience motherhood. The Wiley Protocol has a template for that. Dr. Courtney Ridley has worked with that. I have mixed feelings. If you're going to live long enough to raise a child, maybe. Depends on their health. Depends on their desire. That's up to you, doctor. Family history, breast cancer in a first-degree relative is less than, in relative risk, having a child in your early 40s. Previous benign disease is bigger. So you've got previous benign disease. So you've got cysts, breast lumps. You've got irregular bleeding, considered previous benign disease or atypical hyperplasia. That is a higher risk than any of the ones above, except your location. And cancer in the other breast is less than previous benign disease. So when you look at socioeconomic groups, and again it's 1 and 2, and diet, none of those things matter as much as where you live and whether you've already had problems. Mammograms are more dangerous in this slide than DES and standard of care HRT. Both are as dangerous as drinking alcohol. Premenopausal relative risk, if you're not overweight, 0.7. Premenopausal risk is 2 if you are overweight. That's because you make estrone in your body fat. And estrone converts to estradiol, but it is in a low chronic state. There's no rhythm. And you have insulin and insulin resistance interfering with making progesterone receptors, no matter what age you are. Hence PCOS, PCOD. And then we look at 1.3. We're looking at alcohol consumption. We're looking at exposure to ionizing radiation. Now, is that in an airplane or is that mammograms? It's any female over the age of 10. Taking exogenous hormones, oral contraceptives, aren't as dangerous as using DES in pregnancy, but replacement with big pharmacynthetics used for 10 years is more dangerous than oral contraceptives. The fact is, high-dose synthetic estradiol cured cancer better than any other treatment, and this paper is from 2002, but it was known in the 70s that high-dose estrogen, to turn off the estrogen receptor, now we're talking about G1 arrest, was effective therapy for postmenopausal women and remained the therapy of choice for metastatic breast cancer through the mid to late 70s. So what happened? Estradiol therapy was quickly replaced by tamoxifen, primarily, the literature tells you, because of superior toxicity profile. I would tell you it's because it had no epigenetic changes on the offspring. DES, of course, created cervical cancer in subsequent generations. That would be an epigenetic change. However, long-term follow-up of tamoxifen and DES comparatively in a trial suggested DES was still superior survival in comparison with tamoxifen. Replacement with real bioidentical hormones is not real replacement without a rhythm. One more time, we're going to look at a normal rhythm of ENP. We're going to look at the timing of that rhythm. And then we're going to look at continuous combined, which is, this visual aid shows you Prem-Pro, biased in prometrium, a Vivel patch, and prometrium or progesterone cream. Now this continuous combined shows you starting it at day 14, the luteal phase. However, in number 3, sequential dosing, you're seeing again biased Vivel patch Climera, oral estrogen, and then you're seeing progesterone cream, prometrium, crinone, which is a vaginal approach, for 10 days, which is completely illogical with nature. The Wiley protocol for women is real restoration. Why would you ever start a patient on the Wiley protocol? Well, you would start that patient on the Wiley protocol to establish a normalization of pseudoproduction. And what that means is we're putting it in from the outside. That's exogenous. And doing that, we get real reception of estrogen and progesterone to reproductive levels. This is when the heart disease, diabetes, cancer, Alzheimer's disease, and osteoporosis and arthritis become more rare, become attended to. Symptoms go down and sometimes disappear. So I would tell you, as the inventor and founder of the Wiley protocol, I can't think of any better way to prophylactically prevent major diseases of aging and to make women's quality of life 100 times better on any given day in this very complicated world. If you'd like to go on at this point, you can press the button and I'll tell you how to do it.